Have you ever found yourself just constantly battling fatigue, like a really draining fatigue, even when you're sure you're getting enough sleep? Or maybe it's the opposite. You feel perpetually wired, your heart's racing, maybe a tremor in your hands, just feeling uneasy even when you're trying to relax. A lot of us have felt these things, right? These sort of vague symptoms. And while often the silent orchestrator behind it all is a small but a mighty gland in your neck. Today, we're taking a deep dive into your stack of sources, articles, research, notes, to really unpack what's going on with this tiny but incredibly influential gland, the thyroid. Our mission is pretty clear. We want to arm you with critical knowledge. How your thyroid functions, what happens when it goes wrong. The two main disorders, hypothyroidism and hyperthyroidism. And how they're diagnosed, how they're treated, what the latest research is saying about causes, maybe even breakthroughs. And importantly, what you can actually do day to day to manage your thyroid health.
Yeah, and what's truly fascinating here, I think, and maybe often underestimated, is how this tiny gland, it can weigh less than an ounce, but it wields such profound, such widespread influence over almost every single system in your body. It really does act like a master regulator, sort of a central command for your whole metabolic orchestra. And when it's out of tune, well, the ripple effects are significant. They impact everything: energy, body temp, mood, heart health. Understanding this small player, it's key to grasping a huge piece of your overall well-being.
That master regulator idea, it really sticks. So, okay, let's unpack this. Yeah. How does this tiny gland actually orchestrate so much? What exactly is the thyroid gland, and why is it such a big deal in our bodies?
Right. Well, let's paint a clearer picture. The thyroid is a small butterfly-shaped endocrine gland. Endocrine just means it makes hormones, and it sits right at the base of your neck, just below the Adam's apple. Its primary role, and this is incredibly vital, is to produce hormones that basically regulate your body's metabolism. Think of metabolism as like the engine of your body. All the chemical processes keeping you alive, breathing, thinking, moving. The thyroid. Right. It largely sets the speed of that engine.
Okay, the engine speed. And it's not just one single hormone doing all this, is it? I think our sources mentioned a distinction between what it makes and what actually does the work.
Absolutely. That's a crucial insight. And it's often overlooked. Your thyroid gland primarily produces a hormone called thyroxine, or T4. Now, T4 is kind of like a stored inactive form, a precursor, you could say. For it to actually do anything, it needs to be converted into its active form, triiodothyronine, or T3. And this conversion, it happens inside your cells, mostly through specific enzymes called deiodinases, D1 and D2. So this means you could have plenty of T4 floating around, but if your body struggles with that conversion step, turning T4 into T3, you might still feel the symptoms of an underactive thyroid. It's not just about production, it's about activation. That's what really matters for your energy, your metabolism.
So it's like having a car with a full tank of gas, but the engine isn't properly converting that fuel into actual power. That makes sense then, why its role is so widespread, what truly makes it the master regulator across so many different systems.
Exactly. Continuing that analogy, these thyroid hormones, T3 especially, they act like the body's metabolic thermostat. They don't just regulate one thing. They influence the rate at which almost every single cell in your body functions, every one. That makes them fundamental for your whole energy balance. They directly control how quickly your body converts food into energy, and then how fast it uses that energy. And this has a direct impact on your body composition too. Influencing fat accumulation or loss, what we call adiposity.
Wow.
And beyond that, thyroid hormones are crucial for controlling your core body temperature. Keeps you warm or helps you cool down. They modulate your appetite, help dictate hunger and fullness cues. They even impact your sympathetic nervous system activity, that's your fight or flight response. Influences alertness, stress reaction. So the impact is truly, truly widespread. Yeah. Affects virtually all organ systems: your heart, your brain, your skin, your gut, even reproductive health. For instance, T3 and T4 are absolutely vital for proper fetal nerve development during pregnancy. Just highlights its profound importance right from the start, orchestrating healthy growth.
That's an incredible level of control for such a small gland. It's amazing. And it's not just the thyroid pumping out hormones on its own schedule, right? There's more complexity. A kind of delicate dance, a feedback loop, keeping things in check.
Precisely. Yeah, it's not just left to its own devices. Thyroid function is tightly controlled. It's part of this complex, really beautifully intricate feedback loop. Involves two other key players up in your brain, the hypothalamus and the pituitary gland. The hypothalamus, sort of the brain's command center, sends a signal first to the pituitary gland, the small gland at the base of your brain. The pituitary then responds. It produces thyroid-stimulating hormone, or TSH. Think of TSH as the messenger, or maybe the accelerator pedal, telling your thyroid how much T4 and T3 to make and release. If your T4 and T3 levels dip too low, the pituitary ramps up TSH production. It shouts louder, make more. If they get too high, it dials back the TSH, whispers, okay, ease off. Gah! This continuous monitoring, this fine-tuning, it ensures that delicate balance of hormones in the bloodstream. And it's absolutely essential for optimal health, for all those systems to run smoothly. When this balance gets disrupted, well, that's when we start seeing problems.
Okay, so if the thyroid is our body's accelerator, constantly fine-tuning the engine speed, what happens when it hits the brakes? When it isn't producing enough of those crucial hormones? This is hypothyroidism, right? An underactive thyroid. Sounds like a pretty stark contrast.
It is. It's a very stark contrast. Hypothyroidism, as you said, is a condition where the thyroid gland just can't produce sufficient thyroid hormones, T4 and T3, to meet the body's demands. So instead of running at optimal speed, it's like the engine is stuck in slow motion, leads to a general slowdown of, well, many bodily functions.
And when we look into the causes, our sources really point to one particular culprit being especially common, at least in developed countries.
Yes, that's right. The most common cause in developed countries, especially where dietary iodine intake is generally okay, is an autoimmune disease. It's called Hashimoto's thyroiditis. This is a really fascinating and often challenging condition where, unfortunately, the body's own immune system mistakenly launches an attack. It gradually destroys the very thyroid cells, the follicular cells that produce the hormones. Over time, this chronic attack leads to inflammation and then scarring, or fibrosis, within the gland itself. And this progressive destruction and scarring significantly reduces the thyroid's ability to produce hormones, leads to that slow-down state.
So our own immune system is basically mistaking the thyroid for an enemy and attacking it. That sounds almost counterintuitive, isn't it? Is there anything specific that triggers this kind of autoimmune reaction, or is it just bad luck? And then once it's happening, how do doctors know for sure that it's this autoimmune attack and not just some other reason for an underactive thyroid?
That's an excellent question, the why of the immune system turning on itself. The exact triggers are still being intensely researched, definitely. Genetics plays a huge role, often combined with environmental factors, things that can kind of switch on this predisposition. But to specifically confirm this autoimmune attack, doctors look for hallmark signs in the blood, specific anti-thyroid antibodies. The most common one is thyroid peroxidase antibody, or TPOAB, found in over 90% of people with Hashimoto's. Another important one is thyroglobulin antibody, TGAB, present in maybe 50% to 80% of cases. These antibodies don't just confirm the autoimmune nature, their levels can actually correlate with disease activity, and they suggest a higher chance of developing overt hypothyroidism later on. It's also worth noting, Hashimoto's affects women much more frequently than men, like 7 to 10 times more often, and incidence generally increases with age, mostly seen between 45 and 55.
Given Hashimoto's is so common, are there other reasons, maybe less frequent but still important, why someone might develop hypothyroidism?
Absolutely. While Hashimoto's leads in iodine-replete areas, globally, iodine deficiency is actually the most common cause worldwide, still a major issue in some places. Other causes can happen after medical treatments, like surgical removal of the thyroid, thyroidectomy, or after radioactive iodine, RAI therapy, which is often used to treat an overactive thyroid, ironically. Then there are central issues, problems higher up, like hypopituitarism or central hypothyroidism, where the pituitary or hypothalamus in the brain just fails to signal the thyroid properly. Certain medications can also interfere, things like lithium, amiodarone, some cancer drugs, immune checkpoint inhibitors, tyrosine kinase inhibitors. And interestingly, there's this link with obesity. Higher TSH levels are often seen in individuals with obesity, and these levels tend to come down with weight loss. So just a really complex interplay there.
Right, so we understand why the thyroid might slow down. But for someone living with it, the impact, the day-to-day, that's what really matters. What does that slowdown actually feel like? What are the key symptoms someone might experience with hypothyroidism?
Well, the symptoms are often insidious. They develop slowly. They can be easy to dismiss. You might think, oh, I'm just getting older. I'm just stressed. Patients commonly experience this profound, unexplained fatigue, a fatigue that just doesn't get better with rest. And often, unexplained weight gain, even if diet or activity hasn't changed. They might also feel cold all the time, even when others are perfectly comfortable. That's increased cold sensitivity or cold intolerance.
Yeah, I can imagine how frustrating that must be, just feeling cold and tired constantly. What other changes might people notice?
Many notice changes in their skin and hair. Dry skin is common, brittle nails, hair loss. Digestive issues too, like constipation, that's frequent. And mentally, emotionally. Individuals can experience depression, confusion, and what's often described as brain fog. Just a real difficulty concentrating, thinking clearly. For women, hypothyroidism can have a big impact on reproductive health. It can lead to menstrual irregularities, often heavier periods, sometimes recurrent miscarriages, or difficulty conceiving. Physically, you might see puffiness around the eyes, maybe some swelling in the ankles. Voice changes can happen, muscle aches or weakness, joint aches too. These symptoms, while varied and sometimes nonspecific, they paint a picture of body just struggling to keep up, constantly running sluggishly.
Okay. These symptoms sound pretty widespread, and some are vague, like you said. That must make it tough for people to connect the dots back to their thyroid. So how do doctors accurately diagnose hypothyroidism? And, importantly, distinguish it from other things that might cause similar feelings, like fatigue or brain fog?
That's a critical point distinguishing it. The diagnosis primarily relies on lab tests, blood tests. The hallmark finding in primary hypothyroidism is an elevated TSH level, thyroid stimulating hormone. Remember, TSH is the brain's signal telling the thyroid to work harder. If TSH is high, it means the brain is shouting, but the thyroid isn't responding enough. This high TSH often comes with normal or, in more severe cases, low levels of the active thyroid hormones, free T4 and free T3. Now, if hypothyroidism is confirmed by these levels, then those antibody tests we talked about, TPOAB and TGAB, become crucial. They help identify Hashimoto's as the underlying cause. And again, high antibody levels can also correlate with disease activity, suggest a higher risk of progression.
Okay, and what about those cases where maybe the TSH is a little high, but the actual thyroid hormones T4 and T3 look normal? That's subclinical hypothyroidism, isn't it? Sounds like a real gray area.
It absolutely can be a gray area, and it's a really important nuance in diagnosis and management. Subclinical hypothyroidism is defined exactly like that. Elevated TSH, but normal T4 and T3 levels, and often the person might not feel any symptoms. It can be asymptomatic. Here's a key insight, something that might surprise you. If the TSH is only mildly elevated, say less than 10 MIUL, repeating the blood work in 3 to 6 months is often the recommendation. Why? Because almost half of these mild abnormalities can actually resolve spontaneously, just go back to normal on their own. So it challenges that assumption that any abnormal lab value automatically needs treatment.
Huh. That's interesting. So it might just be a temporary blip for some people?
It can be. However, it's also crucial to know that individuals who do have those TPO antibodies and consistently higher TSH levels, they face a higher risk of progressing to overt hypothyroidism. The risk is about 2-6% per year, maybe even 3-8% if TSH is over 10 and antibodies are positive. So while it can resolve, it definitely warrants careful monitoring. In some cases, a doctor might order a thyroid ultrasound if there's an enlarged thyroid, a goiter, or if nodules are felt, or if the patient has compressive symptoms like trouble swallowing. And because Hashimoto sometimes travels with other conditions like celiac disease or atrophic gastritis, checking iron studies might be done if symptoms suggest it. And vitamin D levels 2 deficiency is pretty common in thyroid disorders.
Okay, so once it's diagnosed, whether it's overt or maybe subclinical, needing treatment, how is this slowdown condition treated? How do you bring things back into balance? What's the standard approach?
The mainstay of treatment, the cornerstone really, is thyroid hormone replacement, primarily using levothyroxine sodium. That's just a synthetic man-made version of T4. This medication essentially replaces the hormone the body isn't making enough of, supplies the fuel the thyroid isn't generating. Now, dosing is highly personalized. It's not one size fits all. A standard initial dose might be around 1.4 to 1.8 micrograms per kilogram per day, but this gets significantly individualized. For older adults or patients with known heart disease, a lower starting dose is typical, maybe 25 micrograms a day, just to avoid putting stress on the heart. During pregnancy, the dose usually needs to go up by about 30%. That's due to increased metabolic demands and the fetus needing that thyroid hormone for development. And patients with conditions affecting absorption, like short bowel syndrome, might need higher doses too.
And I've definitely heard that how you take this medication is incredibly important for it to actually work properly. It's not just about swallowing the pill, but when and with what, right?
It truly is. This is such a critical piece of the day-to-day management puzzle for patients. For optimal absorption, levothyroxine absolutely must be taken on an empty stomach. That usually means first thing in the morning or maybe late at night, away from food. Critically, you need to wait at least 30 minutes before eating or drinking coffee, and even longer, like 4 hours before taking supplements containing iron, fiber, calcium, multivitamins, or soy. These things can actually bind to the medication in your gut and prevent it from being absorbed properly. Certain acid-blocking medications can also interfere, so careful scheduling is just vital. Regular follow-up is key too. Blood tests, TSH, T4, T3, and reviewing symptoms. This allows for periodic dosage adjustments to keep the patient euthyroid, meaning normal thyroid function. For Hashimoto's patients who are still euthyroid but at risk, annual testing is generally recommended.
What about those folks with subclinical hypothyroidism, that wait and watch group? Do they eventually get treated, or is it always just monitoring?
For subclinical hypothyroidism, yeah, the initial approach is often that wait and watch strategy, especially if the TSH elevation is mild. However, levothyroxine therapy is generally recommended if the TSH is consistently above 10 MIUL, or if the patient is experiencing clear hypothyroid symptoms, even with a lower TSH. Also, if TPO antibodies are positive, that increases the likelihood of progression, so treatment might be considered sooner. And definitely for women of reproductive age, especially if they are trying to conceive. Thyroid health is crucial for pregnancy, but this leads to a really important takeaway, something that might challenge common thinking. For many people, particularly older individuals who are asymptomatic, even with mildly elevated TSH, large-scale studies like the TRUST trial or Cochrane reviews, they haven't consistently shown significant improvement in symptoms, mood, or quality of life, even when treated with levothyroxine. It really highlights the complexity. It challenges the idea that every abnormal lab value needs a pill, emphasizes personalized care, looking at the whole picture, symptoms included, not just the numbers.
Fascinating. Okay, now let's flip that coin. We've talked a lot about the thyroid hitting the brakes, slowing things down. What happens when it goes into overdrive, releasing way too much hormone? That's hyperthyroidism, right? A state where everything in your body feels like it's running on overtime.
Hyperthyroidism is indeed the opposite end of the spectrum. And yeah, it can be quite a jarring experience for people. It's a syndrome characterized by excessive production and release of thyroid hormones. Leads to this hypermetabolic state and also a hyperadrenergic state, like your adrenaline system is constantly activated. Imagine your metabolic engine just stuck in high gear, constantly revving.
And just like hypothyroidism has a main cause in Hashimoto's, what's usually behind this overdrive state? What's the most common reason?
The most common cause, especially in younger and middle-aged adults, is Graves' disease. This is another autoimmune condition, but it works completely differently than Hashimoto's. In Graves' disease, the body produces specific antibodies called thyrotropin receptor antibodies, or TRAB. These antibodies mistakenly stimulate the TSH receptor on the thyroid cells. They act like a constantly pressed accelerator pedal. So these TRAB antibodies mimic TSH, causing the thyroid to just churn out excessive amounts of T3 and T4. This overstimulation also leads to the growth and increased blood flow to the thyroid gland itself, often causing a goiter. Graves' disease is the most prevalent cause of hyperthyroidism. Affects maybe 15 to 45 people per 100,000 per year, most common between 30 and 50. And again, women are more frequently affected than men. What's particularly distinct about Graves', though, is that the autoimmune reaction can also target tissues behind the eyeball. Leads to those specific eye symptoms people sometimes associate with it.
Ah, okay. So that's why some people with Graves' disease have those characteristic eye issues, often described as bulging eyes.
Exactly. Those are known as extrathyroidal manifestations, meaning outside the thyroid gland itself. Beyond Graves', other common causes include toxic multinodular goiter, or TMNG, that's characterized by multiple small lumps or nodules within the thyroid that just start autonomously producing excessive hormones independent of any TSH signal. This tends to be more prevalent in older adults and also in regions where iodine deficiency has been common. Another cause is a toxic adenoma. That's a single autonomously functioning thyroid nodule that overproduces hormones. Just one rogue nodule causing trouble.
Okay, so Graves' multiple nodules, a single nodule. Are there any other maybe less common triggers that can send the thyroid into hyper mode?
Yes, there are several others. Interestingly, excessive iodine intake, which can cause hypothyroidism in some, can actually trigger hyperthyroidism in others, especially in those with pre-existing thyroid conditions or an area transitioning from iodine deficiency. It's complex. We also see less common causes like TSH secreting pituitary adenomas, a tumor in the pituitary making too much TSH, or conditions with very high levels of human chorionic gonadotropin, HCG, like certain rare pregnancy-related tumors. Sometimes thyroid tissue can even be found outside its normal location, like in ovarian teratomas, a condition called struma ovariae, where the ovarian tumor itself makes thyroid hormones. Certain medications can also induce thyroiditis, inflammation of the thyroid, causing a transient hyperthyroidism due to hormone leakage. Drugs like amiodarone, lithium, certain cancer treatments, immune checkpoint inhibitors, other forms of thyroid inflammation too. Hashimotoxicosis, that's a temporary hyperthyroid phase, sometimes seen early in Hashimoto's, as the gland leaks hormones while being destroyed. Also, painless thyroiditis, painful subacute thyroiditis, suppurative thyroiditis. These can all cause temporary hyperthyroidism. And finally, there's factitious thyrotoxicosis. That's simply taking too much thyroid hormone medication, either accidentally or sometimes intentionally, maybe for weight loss.
Wow, okay. It really sounds like there are many potential culprits that can push the thyroid into overdrive. So what does this overdrive state actually feel like for someone experiencing it? What are the key symptoms people might notice?
Patients often describe it as feeling like they're constantly on edge, like their body is just running at this accelerated, uncontrolled pace. Common symptoms include unintentional weight loss, which is interesting because appetite is often increased. They're burning calories so fast, there's often a profound heat intolerance. Feeling hot all the time, excessive sweating, making warm environments just unbearable. Cardiovascular signs are very prominent. Palpitations, feeling your heart race or pound. A consistently fast heart rate called tachycardia. High blood pressure is common too. In severe cases, it can even lead to serious heart rhythm problems like atrial fibrillation or even signs of heart failure. Host, speaker. That sounds incredibly alarming. To constantly feel your heart pounding like that, it can be very frightening. Neurologically and psychologically, individuals might experience tremors, especially noticeable in the hands. Nervousness, anxiety, irritability, restlessness, these are very common, and significant sleep disturbances. Hard to wind down when your engine is revving. Other physical changes can include muscle weakness. Despite feeling restless, the muscles can feel weak. Fatigue can also be present, oddly enough. Increased frequency of bowel movements, sometimes even diarrhea. Hair loss can occur. Loss of libido. And irregular menstrual periods in women, often lighter, infrequent, or absent periods, oligomenorrhea or amenorrhea.
And for Graves' disease specifically, you mentioned those eye symptoms earlier. Can you elaborate a bit more on those? They seem quite distinctive.
Yes, for Graves' disease, the extrathyroidal signs are indeed quite distinct. Thyroid eye disease, or Graves' ophthalmopathy, involves specific eye symptoms. Things like proptosis, that's the bulging of the eyes, diplopia, which is double vision, excessive tearing, redness of the whites of the eyes, conjunctival injection, and a sensation of pressure or pain behind the eyes. It's a key feature of Graves', though it's interesting. Up to 6% of Hashimoto's patients who happen to have those stimulating TSH receptor antibodies can also experience some eye involvement. Rarer but very specific signs of Graves's can include skin changes like pretibial myxedema, that's thick, waxy, scaly skin plaques and swelling, usually on the lower legs, and thyroid acropaky involving soft tissue swelling of the hands and clubbing of the fingers. Very rare, but specific. And a diffuse non-nodular enlargement of the thyroid gland, a goiter, is also very common in Graves's.
With such a broad range of symptoms and some overlap with things like anxiety,
Yeah.
how do clinicians accurately diagnose hyperthyroidism and then pinpoint the precise cause, whether it's Graves or nodules or something else?
Right. Diagnosis starts, again, primarily with lab tests, blood work. Confirmation of hyperthyroidism involves finding low or suppressed TSH levels, usually accompanied by elevated free T4 and/or total T3 levels. If that TSH is very low, close to zero, it's a strong indicator the thyroid is overactive, telling the brain, stop stimulating me. There's that specific variant called T3 toxicosis, where only the T3 is elevated, T4 is normal, but TSH is still suppressed. It's also really important to be aware of potential lab interference. High biotin intake, for example, found in many hair and nail supplements, can mess up the tests. It can cause falsely low TSH and falsely high T4 levels. So if you're taking biotin, it's absolutely crucial to tell your doctor before having thyroid tests done. Stop it for a few days beforehand.
Good tip. Okay, so once hyperthyroidism is confirmed by the low TSH and high hormones, how do you figure out the cause? Like, how do you know if it's Graves' then?
To pinpoint Graves' disease specifically, measuring those thyrotropin receptor antibody, TRAB levels, is the key step. Elevated TRAB levels strongly correlate with Graves' disease, and the newer lab assays for these antibodies are very sensitive and specific, like 98, 99.9% accurate for some types.
Okay, but what if those TRAB levels come back normal? What's the next step then to figure out if it's nodules or maybe thyroiditis?
If TRAB is normal, then a radioiodine thyroid uptake and scan is often the next step. Uses a tiny safe amount of radioactive iodine, usually I-123 isotope. This test shows the pattern of iodine uptake by the thyroid gland. It helps differentiate the causes really well. For instance, Graves' disease typically shows increased uptake diffusely throughout the whole gland. Toxic nodules, on the other hand, show localized hot spots where the nodules are actively taking up iodine and making hormone, while the rest of the gland might be suppressed. And thyroiditis inflammation often shows very low uptake because the inflamed gland isn't actively taking up iodine. It might just be leaking stored hormone. It's a very effective diagnostic tool. But again, super important. It's contraindicated, meaning shouldn't be used in pregnant or lactating women due to the radioactivity.
Right, safety first. Are there other imaging options besides the radioactive scan?
Yes, another valuable tool is a thyroid ultrasound, often combined with color Doppler imaging. This imaging technique can show specific structural features, and the color Doppler shows blood flow. Increased arterial blood flow throughout the gland, sometimes described vividly as a thyroid inferno, is very characteristic of Graves' disease. In contrast, low blood flow is typically seen in destructive thyroiditis. This can be particularly useful, for instance, in differentiating between different types of amiodarone-induced thyrotoxicosis, where one type is inflammatory, low flow, and the other involves excess hormone production, high flow.
Okay, so once the cause is nailed down, what are the treatment options for bringing that revving thyroid engine back to a normal speed? It sounds like you need to slow things down pretty quickly sometimes.
You're right. Immediate symptomatic relief is often a priority because that overdrive state can be very distressing and potentially dangerous, especially for the heart. So, beta-adrenergic antagonists, beta blockers like atenolol or propranolol are commonly used first. They help control symptoms like rapid heart rate, tremors, anxiety. They don't fix the thyroid problem itself, but they make the patient feel much better and safer while the definitive treatment takes effect. For people who can't tolerate beta blockers, maybe due to asthma, calcium channel blockers like verapamil can be a second-line option for symptom control. Then you move on to the definitive treatments aimed at the thyroid itself. The choice here is highly individualized. Depends on the cause, the patient's age, other health conditions, pregnancy status, and importantly, patient preference.
Okay, so what are those main definitive treatment options? You mentioned 3 earlier, I think.
Yes, the 3 main pillars are antithyroid drugs, radioactive iodine therapy, and surgery. First, antithyroid drugs or ATDs. The main ones are methimazole, generally preferred because it's usually once daily dosing and has a slightly better safety profile overall. And propylthiouracil, or PTU, how they work. They act as competitive inhibitors of an enzyme called thyroid peroxidase, TPO. This blocks the synthesis, the making of new thyroid hormones. PTU has an added bonus. It also blocks some of the peripheral conversion of T4 into the more active T3. Treatment with ATDs typically continues for about 12 to 18 months. Then, doctors often check TRAD levels again to see if remission has occurred. Remission rates vary quite a bit geographically, maybe 20–30% in U.S. studies, but higher, like 50–60% in European and Japanese populations. For pregnancy, PTU is the preferred choice in the first trimester. That's because methimazole has a slightly higher risk, though still low, of causing certain congenital defects early on. After 16 weeks gestation, it's often safe to switch to methimazole, but it's crucial to be aware of potential side effects of ATDs. Rare but serious ones include a granulocytosis, a severe drop in white blood cells, making you very prone to infection, and hepatotoxicity, or liver damage. PTU is more associated with hepatocellular damage, methimazole more with cholestatic.
Okay, so drugs are one option, often for a year or more. But what about radioactive iodine and surgery? How do they fit in as more, maybe, permanent solutions?
Right. Radioactive iodine, or RAI, therapy. This involves taking a capsule containing a specific radioactive iodine isotope, usually I-131 for treatment. This isotope gets absorbed by the overactive thyroid cells, just like regular iodine would. But the radioactivity then destroys those thyroid follicular cells, the ones making too much hormone. This reduces hormone production permanently. It's often considered a definitive, long-term solution. Simple procedure, just swallowing a pill. A key consideration, though, RAI can sometimes cause a temporary worsening of hyperthyroidism called radiation thyroiditis as stored hormones leak from the dying cells. This can be a concern for patients with significant heart disease. So pretreatment with ATDs for a while first is often recommended in those cases. And importantly, RAI very often leads to permanent hypothyroidism down the line. So most patients will eventually need lifelong levothyroxine replacement therapy. But many find this a reasonable trade-off to cure the hyperthyroidism.
Okay, so RAI is essentially knocking out the thyroid function. What about just removing the gland surgically? Thyroidectomy.
Thyroidectomy, the surgical removal of part or all of the thyroid gland, is the third main option. It's recommended in several situations, when ATDs don't work, aren't tolerated, or cause severe side effects. Also for patients with very large goiters that are causing compressive symptoms, difficulty breathing or swallowing, or if there's a suspicion of thyroid cancer within the gland. And sometimes, simply for patients who desire an immediate and definitive resolution, maybe because they're planning a pregnancy soon after treatment. Before surgery, sometimes a special iodine solution, Lugol's iodine, is given for about 10 days to help reduce blood flow to the gland, making surgery safer. A laryngeal nerve examination to check vocal cord function beforehand is also standard because those nerves run right near the thyroid and can potentially be injured during surgery. After a total or near total thyroidectomy, patients, just like after RAI, will typically require lifelong levothyroxine replacement. Potential complications of surgery, though generally low in experienced hands, include hypercalcemia, low calcium levels, if the nearby parathyroid glands are accidentally injured or removed. Also, recurrent or superior laryngeal nerve paralysis affecting the voice. And hemorrhage or infection, like with any surgery.
So 3 very different approaches: drugs, radiation, surgery. And what about subclinical hyperthyroidism? Is that treated similarly to subclinical hypo, where it's sometimes wait and watch?
Yes, exactly. Treatment for subclinical hyperthyroidism is also nuanced. It's not always necessary immediately. It's generally considered for specific profiles. If the TSH is very suppressed, like less than in a zero point 0.1 MIUL, especially in individuals over 65, or in those under 65 who have other health issues like cardiovascular disease, osteoporosis, or if they have significant hyperthyroid symptoms despite only subclinical labs. It might also be considered if TSH is just moderately low, between zero point 0.1 and zero point 0.4 in individuals over 65 or with those comorbidities, if the TSH stays suppressed after monitoring for 3 to 6 months. So again, it highlights that not every lab deviation needs immediate aggressive intervention. It requires careful, personalized assessment of risks and benefits.
Okay, we've covered the what, the why, the how of diagnosis and treatment. But this next area, this is where it gets really interesting, I think. How integrated our bodies are. What role do our daily choices, our lifestyle, what we eat, our environment play in thyroid health? And how does it all connect to our broader metabolic well-being?
Yeah, this is such a critical area because diet and environmental factors, they have direct and sometimes surprising influences on thyroid conditions. And it's something you potentially have some control over. Take iodine intake, for instance. We need iodine. It's absolutely essential for making thyroid hormones. But excessive iodine can be detrimental. Here's a key insight from the sources. Excess iodine is a significant environmental factor influencing autoimmune thyroid conditions. Too much iodine supplementation can actually worsen Hashimoto's thyroiditis in some people, and it can even directly cause Graves' disease in susceptible individuals. We've seen studies where daily iodine consumption reached 1 milligram in large U.S. populations, which can definitely be problematic. And geographically, it's interesting. Autoimmune disorders like Graves's tend to be more common in areas where iodine intake is generally sufficient or high, whereas nodular thyroid diseases like toxic multinodular goiter are more common in historically iodine-deficient regions. It's a really delicate balance.
Wow, so it truly is a Goldilocks situation. With iodine, too little is bad, but too much can also stir up trouble, especially with autoimmunity. Are there other nutrients that are important, maybe like cofactors that help the thyroid do its job properly?
Yes, definitely. Selenium is another key mineral player here. Selenium is essential for normal body function anyway, involved in antioxidant defense, immune function, and other things. Studies have linked decreased selenium levels to the development of Graves' disease. Conversely, selenium supplementation has shown some promise, particularly in Hashimoto's. It might help improve thyroid function and reduce those TPO antibody levels, especially in individuals who live in areas known to be selenium deficient. Studies from places like India, China, Greece have reported some positive effects with supplementation. Similarly, vitamin D deficiency. It's increasingly identified as an environmental factor that can influence thyroid function and autoimmune conditions like Graves'. While we probably need more large-scale studies to confirm clear benefits across the board, correcting vitamin D deficiency may be helpful in Hashimoto's. Some trials have shown reduced antibody levels and improved TSH after supplementation.
What about iron? We often hear about iron for energy, preventing anemia. Does it play a role specifically with the thyroid too?
It does seem to. Studies have demonstrated an inverse association between serum iron levels and Hashimoto's, meaning lower iron levels seem linked to a higher risk. One study even showed that for women of reproductive age, every unit increase in serum iron level was associated with a significant, like 43% decrease in the risk of Hashimoto's thyroiditis. It really highlights how interconnected these nutrients are for thyroid health. And beyond directly influencing the disease, dietary factors are critical for medication absorption. As we talked about with levothyroxine, food, coffee, and supplements like iron, fiber, calcium, soy, multivitamins, they can all significantly interfere if not timed correctly. That's a crucial daily management piece.
Absolutely. And there's been a lot of buzz around autoimmune diets or anti-inflammatory diets for various conditions. What's the connection, if any, specifically for thyroid autoimmunity? Is there solid evidence?
Yeah, that's a common question. The evidence specifically supporting these diets for thyroid conditions is still somewhat limited, honestly. We need more robust research. But the underlying theory often involves what's sometimes called leaky gut syndrome or increased intestinal permeability. The idea is imagine your gut lining as a tight barrier. If it becomes damaged or more permeable, maybe due to inflammation, stress, certain foods, it might let larger protein molecules from food or bacterial components pass through into the bloodstream where they shouldn't be. Your immune system sees these as foreign invaders and mounts a response. Now, here's the molecular mimicry part. If some of these invader proteins happen to share structural similarities with proteins in your own thyroid gland, like thyroid peroxidase, the immune system might get confused and start attacking your thyroid by mistake, thinking it's the foreign invader. It's an intriguing hypothesis linking gut health to autoimmunity, and it continues to be researched actively. But we need more direct evidence for specific dietary protocols in thyroid disease.
Interesting connection, that gut health link. Okay, so diet directly impacts the thyroid, medication absorption, and maybe even autoimmunity. What about exercise? How does physical activity intertwine with thyroid function and our overall energy metabolism? It seems like it would be a huge factor.
It absolutely is a huge factor. Exercise and thyroid function are deeply interconnected through energy metabolism. Thyroid hormones are key regulators of your metabolic rate, right? They influence both your resting energy expenditure, the calories you burn just sitting around, and your active energy expenditure during physical activity. Thyroid hormones also have direct effects right down at the cellular level on how your cells create and use energy ATP utilization, mitochondrial function. They control core body temperature too. In certain types of fat tissue, brown adipose tissue, or BAT, active T3 stimulates a protein called UCP1, which generates heat. That's crucial for adaptive thermogenesis. There's also research looking into the browning of white fat tissue, where white fat cells take on some characteristics of brown fat cells. This might be stimulated by thyroid hormones too, potentially increasing energy expenditure, though the human evidence for a significant thermogenic effect from this mechanism is still a bit scarce.
And what if someone has an underactive thyroid, hypothyroidism? Does exercise still help them? Or is it just too difficult to even get started when you feel so sluggish?
That's a really important point. It is often difficult to get started because subclinical hypothyroidism is clearly associated with decreased muscular strength and reduced exercise capacity. That's a big part of why people with an underactive thyroid often feel so fatigued and struggle with physical activity. However, studies have consistently shown that normalizing TSH levels with levothyroxine treatment can lead to significant improvements in exercise performance and capacity. It really underscores the thyroid's fundamental role in our physical ability to function, and it highlights that getting treated effectively can absolutely help you regain that capacity for activity. Exercise then becomes a beneficial part of management.
So it really sounds like a two-way street then, between thyroid function and broader metabolic health, things like metabolic syndrome. It's not just the thyroid acting in isolation, but influencing and being influenced by other metabolic systems.
That's a very perceptive way to put it. It's absolutely a bidirectional link, a two-way street. Metabolic syndrome, or METS, remember, is that cluster of risk factors. Excess belly fat, central adiposity, high blood glucose or insulin resistance, abnormal lipid levels, high triglycerides, low HDL good cholesterol, and high blood pressure. Together, these dramatically increase the risk of heart disease and type 2 diabetes. The key clinical insight here is that thyroid dysfunction, both hypo and hyper and metabolic syndrome, are very frequently observed together in patients. They often coexist, highlighting this complex, intertwined relationship.
So how does having excess weight or metabolic syndrome itself then influence the thyroid? Does it actually mess with the thyroid's ability to function properly?
It certainly can, through several really fascinating mechanisms that researchers are uncovering. Leptin, for example, that's a hormone primarily produced by fat tissue. It plays a role in regulating appetite, but it also modulates the thyroid axis. While a reduction in leptin during severe dieting can contribute to suppressing thyroid function, the body trying to conserve energy, the role in obesity, where leptin levels are typically high, is complex. Some evidence suggests high leptin might actually inhibit TSH secretion and thyroid protein expression. Perhaps more clearly, adipose tissue, especially in obesity, is known to secrete pro-inflammatory cytokines, signaling molecules like TNF-alpha, IL-1, IL-6. These inflammatory signals can directly interfere with thyroid function. They can inhibit the expression of NIS, the sodium iodide supporter, which is crucial for getting iodine into the thyroid cell to make hormones. They can also mess with the diadenese enzymes that convert T4 to T3, potentially contributing to lower active T3 levels, sometimes called low T3 syndrome or non-thyroidal illness syndrome, often seen in chronic inflammatory states like obesity. And lastly, insulin resistance. A hallmark of METS and often linked to obesity, seems to lead to an increase and augmentation of serum TSH levels. Supporting this link, the drug metformin, which improves insulin sensitivity, has been shown in some studies to cause a reduction in serum TSH levels.
That's incredible, that excess body fat can actually trigger inflammation that directly impacts hormone production and conversion. And then looking the other way, how does thyroid dysfunction hypo or hyper then impact all those components of metabolic syndrome like weight, blood sugar, cholesterol?
Right, the influence definitely goes both ways. Thyroid dysfunction directly impacts METS components. Regarding adiposity or weight, thyroid hormones, as we know, directly regulate metabolic rate. They also influence appetite control and sympathetic nervous system activity, all of which play into weight gain or loss. Researchers are even looking at newer thyroid hormone metabolites like 3000-diodoyl-thionine or T2. Animal studies suggest T2 might have promising effects in preventing diet-induced adiposity, acting perhaps more selectively on metabolism than T3 or T4. Other related compounds called thyroamines can even have effects opposite to T3. This opens new avenues for potentially targeting metabolism, though human relevance needs much more research. For glucose metabolism, hyperthyroidism is clearly linked to peripheral insulin resistance. This happens partly because it reduces glucose uptake by cells, making it harder for the body to use sugar effectively. Conversely, hyperthyroidism tends to increase blood glucose levels, largely by boosting the liver's production of new glucose, gluconeogenesis. Thyroid hormones directly regulate the genes involved in how the liver makes sugar, stores it as glycogen, and responds to insulin signals. Intriguingly, research suggests a kind of U-shaped pattern of risk for diabetes. Both hyperthyroidism and hyperthyroidism, including their subclinical forms, seem to be associated with a higher risk of developing type 2 diabetes mellitus. It suggests optimal thyroid function is really important for glucose balance.
That's quite a strong connection, affecting blood sugar potentially quite dramatically depending on whether the thyroid is over or underactive. What about cholesterol and blood pressure?
Yes, significant effects there too. For lipid metabolism, hypothyroidism typically leads to higher serum triglycerides and higher LDL-C, the bad cholesterol. This is partly due to reduced expression of LDL receptors on the liver, which normally clear LDL from the blood, and changes in key genes involved in fat metabolism. Hyperthyroidism, on the other hand, tends to stimulate both the synthesis and the breakdown of lipids. Often, the net effect is an increase in lipolysis, the breakdown of fats from fat stores, which can sometimes lower cholesterol levels, but it's complex. Again, that T2 metabolite has shown potential lipid-lowering actions in rodent studies affecting how the liver processes fats. Finally, for blood pressure, both subclinical hypothyroidism and subclinical hyperthyroidism have been associated with higher blood pressure levels. Thyroid hormones act directly on the blood vessels and the heart through specific receptors, TRA and TR, regulating numerous genes involved in cardiac function, vascular tone, and resistance. So they have a direct influence on blood pressure regulation. This whole intricate network really drives home how fundamental thyroid health is to our overall metabolic balance. It's a constant, complex dialogue happening inside the body.
Okay, so we've gone deep into the mechanics, the symptoms, the treatments, the lifestyle connections. But what's next? What's on the horizon in thyroid research? What are scientists learning about the really intricate underlying causes of these conditions, especially the autoimmune ones like Graves and Hashimoto's? And maybe more importantly for patients, are there any true breakthrough treatments emerging, things that could really change how we approach thyroid disease in the future?
This is an incredibly active and frankly exciting area of research right now, particularly in unraveling the autoimmune origins of Graves and Hashimoto's. It's complex. Scientists are looking beyond just general genetic predispositions. They're digging into specific immune genetics, like the human leukocyte antigens or HLAs located on chromosome 6. These HLA genes are critical in how our immune system presents antigens foreign or self, and how it activates T cells, the immune system's soldiers. Variations here can definitely increase susceptibility. There's also intense investigation into mutations in other genes like CD25, part of the IL-2 receptor, and CTLA4, a key T cell checkpoint inhibitor. These genes are involved in maintaining immune tolerance, basically preventing the immune system from attacking itself. Defects here might reduce central T cell tolerance, leading to autoimmune responses.
So our genetics really can prime us, kind of setting the stage for an autoimmune reaction if other factors come into play.
Yeah.
What else is contributing to this deeper understanding? What about epigenetics?
That's a huge piece of the puzzle. The observation that identical twins have about a 75% concordance rate for Graves' disease, meaning if one twin has it, the other has a 75% chance, strongly suggests epigenetics plays a major role. Remember, epigenetics refers to modifications to gene expression that don't actually change the underlying DNA sequence. Think of them as sticky notes on the DNA, telling genes whether to be switched on or off. Research is actively exploring alterations in these epigenetic patterns, things like DNA methylation, histoneacetylation, methylation that might influence immune cell function and make someone more susceptible to developing autoimmune thyroid disease. We're also gaining a much deeper understanding of the specific cellular players involved, especially B cells and T cells. B cells are clearly central. In Graves', they produce those stimulating Trab antibodies. In Hashimoto's, they produce the TPOAB and TGAB antibodies that mark the thyroid for destruction. New research is meticulously mapping the specific parts of thyroid proteins, the B-cell epitopes that these antibodies recognize, and exploring therapies that might directly target or modulate these B cells.
Okay, so targeting the antibody-producing B cells makes sense. What about the T cells?
T cells are crucial too. Different subsets of T cells, helper T cells like Th1, Th2, Th17, and also regulatory T cells or TREGs, plus the cytotoxic CD8, plus T cells that can directly kill thyroid cells, all contribute to the pathogenesis. In Graves', the early phases might involve more Th1 activity, promoting inflammation. Later stages might shift towards Th2 activity, helping B cells make antibodies. In both Graves' and Hashimoto's, a common finding seems to be a reduction in the number or function of TREGs. These TREGs normally act as the immune system's brakes, suppressing excessive immune responses. If they're not working properly, inflammation can run rampant. There's also research into natural killer NK cells. Some studies observed decreased levels of NK cells in Graves' patients. One hypothesis is that this decrease might allow B cells to proliferate more and make more autoantibodies, but this area is still a bit controversial and needs more investigation.
That's a lot of complex immune system interplay. It really suggests the root cause is often deeper than just the thyroid gland itself malfunctioning. Are researchers identifying any external triggers that might kick off these autoimmune processes? Like infections. You mentioned molecular mimicry earlier.
Yes, the molecular mimicry idea linking infections to autoimmunity is gaining more evidence. Research has shown a link, for example, between infection with a bacterium called Yersinia enterocolytica and Graves' disease. The theory is that memory B cells, after encountering certain proteins on the surface of this bacteria, might develop cross-reactivity. They mistakenly recognize the TSH receptor on the thyroid because it has some structural similarities to the bacterial protein. It's like the immune system learns to fight the infection but then accidentally targets the thyroid because it looks similar. Similarly, hepatitis C virus infection, and especially its treatment with interferon alpha, is known to predispose people to autoimmune thyroid diseases like Graves'. Again, potentially due to similarities between viral proteins and thyroid proteins. Other viruses, like retroviruses and parvovirus B19, are also under investigation. Furthermore, scientists are exploring novel biomarkers, things beyond just hormone levels or antibodies. For instance, microvesicles, tiny particles shed from cells during stress or death, have been found at higher levels in the blood of Graves' disease patients, even after treatment. This could potentially lead to new ways to diagnose or monitor disease activity in the future.
It's really incredible how much is being uncovered about the fundamental causes. Shifting gears slightly, what about the other side of the coin, true breakthrough treatments? Are there emerging therapeutic avenues that could genuinely change how we manage thyroid disease, especially the autoimmune forms?
Yes, there are some very promising developments, particularly for some of the more challenging aspects of these diseases. One of the therapies, often highlighted as a potential breakthrough, especially for the debilitating eye symptoms of Graves' eye disease, is an antibody therapy targeting the insulin-like growth factor 1 receptor, or IGF-1R. Teprotumumab is the name. This receptor is found on fibroblasts, the cells behind the eye that get activated in Graves' ophthalmopathy, causing inflammation and tissue expansion. By blocking IGF-1R signaling, this antibody therapy directly addresses the underlying mechanism of the eye disease, offering targeted relief for patients suffering from proptosis and double vision. It's a significant advance.
That sounds like a truly targeted approach, especially for that specific difficult manifestation of Graves'. What else is being developed to perhaps modulate the immune response more broadly?
Given the strong evidence implicating B cells in Graves' disease, making the tree of antibodies, therapies that target B cells are proving efficient. For example, rituximab, an anti-CD20 therapy that depletes B cells, has shown effectiveness in some studies for difficult-to-treat Graves' disease or Graves' ophthalmopathy. This opens new avenues by directly modulating the immune response rather than just managing hormone levels. Looking further ahead, future treatments for Graves might focus on restoring immune tolerance, essentially retraining the immune system not to attack the thyroid. Leveraging regulatory B cells, BREGs, which can suppress immune responses, is one area of interest. If we can understand how to boost or utilize BREGs effectively, it could lead to new B cell mediated therapeutic strategies aiming for long term remission without broad immune suppression. And finally, while still very much in the research phase, exploring those thyroid hormone metabolites like T2 and the thyronamines is fascinating. T2, as mentioned, showed potential in animal models for preventing diet-induced adiposity, possibly acting more on fat burning than T3. While its human physiological role and clinical relevance are still unclear, it offers a glimpse into future metabolic treatments that might be more targeted or have fewer side effects than current therapies. But that's definitely further down the road.
So, pulling this all together, what's the long game here? For someone diagnosed today with thyroid disease, what does the future generally look like? And maybe most importantly, what are the practical, actionable steps that patients and their families can take every single day to manage their health effectively and really thrive?
While the long-term outlook, the prognosis for most individuals with thyroid disease is generally quite positive, and that's largely thanks to the effective management strategies we now have. For Hashimoto's thyroiditis, many people remain euthyroid with normal function for extended periods, but they do carry about a 5% risk per year of eventually developing overt hypothyroidism, which just underscores the need for lifelong monitoring, usually annual checkups. With subclinical hypothyroidism, remember, about half of those with mild dysfunction might see their TSH levels normalize spontaneously within a year or two. However, about 25% will likely progress to overt hypothyroidism, so regular monitoring is essential there too, especially for those with higher TSH levels initially or positive TPO antibodies. For hyperthyroidism, including Graves' disease and toxic nodular goiter, patients generally have very good outcomes. That's due to the high success rates of the definitive treatments, whether it's antithyroid drugs, radioactive iodine, or surgery. Remission rates for Graves after a course of ATDs, for instance, while variable, show that a significant portion of patients can achieve long-term stability.
That's definitely reassuring to hear, that most people can find a good path forward with proper management. But what happens if these conditions aren't managed properly? Or if diagnosis is delayed? Are there serious, maybe even life-threatening complications to be aware of?
Unfortunately, yes. Untreated or poorly managed thyroid disease can lead to significant, serious complications. For hyperthyroidism, the most acute danger is thyroid storm or thyrotoxic crisis. This is a rare but severe, life-threatening surge of hyperthyroidism. It has a high mortality rate, estimated around 16%, especially in older individuals. It's a medical emergency. Long-term, untreated, or poorly controlled hyperthyroidism significantly increases the risk of serious cardiovascular problems, acute events, atrial fibrillation, that irregular heart rhythm, ischemic stroke, also osteoporosis, infertility, menstrual cycle abnormalities, and overall increased mortality. Even subclinical hyperthyroidism, the kind without obvious symptoms, isn't benign. It's linked to an increased risk of arrhythmias like atrial fibrillation, osteoporosis, hip fractures, and higher mortality over time.
Okay, so the risks are definitely real, especially with hyperthyroidism. What about the risks on the hypo side?
Untreated hypothyroidism, or even persistent subclinical hypothyroidism, also carries risks. It's associated with an increased risk of coronary artery disease, congestive heart failure, and fatal stroke. Other potential impacts include cognitive decline. Those studies here are a bit conflicting on the extent and reversibility. Mood disturbances are clearly linked. There's about a 1.7 times higher risk of depression in individuals under 60 with hypothyroidism. Decreased kidney function can occur, and as we discussed, reduced muscular strength and exercise capacity. One other specific risk for Hashimoto's patients, they are at an increased risk compared to the general population for developing a rare type of thyroid cancer called primary thyroid lymphoma. It only accounts for maybe 0.55% of all thyroid malignancies, but the link is there. The association with the much more common papillary thyroid cancer is less clear and still debated.
Given these potential complications, both short-term and long-term, it's crystal clear that proactive, consistent management is absolutely crucial. So beyond just taking the prescribed medication, what can patients and their families really do in their daily lives? What are the practical, actionable steps to manage thyroid health effectively and prevent these issues from escalating? What's the takeaway advice?
A crucial element, maybe the most empowering one, is fostering a strong partnership between the patient and their physician. It's a team effort. The physician brings the expertise for vigilant assessment, interpreting tests, adjusting doses appropriately, but the patient's role is equally vital. Medication adherence is key. self-monitoring for symptoms, and reporting any changes in health status promptly. Open communication is essential, and medication adherence, especially for levothyroxine, is absolutely paramount. Strict adherence to those instructions we talked about, taking it on an empty stomach, timing it away from interfering foods and supplements like iron, fiber, calcium, soy, multivitamins, is non-negotiable for it to work effectively. Even acid-blocking medications can interfere. These seemingly small daily habits make a huge difference in treatment success.
Right. Really understanding your medication and how it fits into your daily routine is fundamental to making it effective.
Absolutely. Patients should also be well educated on recognizing the symptoms not just of their primary condition, but also the opposite. Someone with hypo should know the signs of becoming hyper if their dose is too high, and vice versa. And knowing the warning signs of severe acute complications like thyroid storm and hyperthyroidism, or myxedema coma in severe hypothyroidism, though very rare now, prompt reporting of any concerning changes to healthcare providers is critical. Regular monitoring is also part of that daily management mindset. Annual thyroid function tests are generally recommended for individuals diagnosed with Hashimoto's or those being monitored for subclinical hypothyroidism to track progression or ensure treatment is still optimal.
Okay, so partnership, medication diligence, symptom awareness, regular checks. What about diet and lifestyle beyond just avoiding interference with meds?
In terms of diet, the main thing is usually avoiding excessive iodine intake, especially for those with autoimmune thyroid conditions, as it can potentially exacerbate the disease. Focus on a balanced diet. Discussing potential supplementation of selenium, vitamin D, or iron with a doctor is reasonable if deficiencies are identified through testing or if someone lives in an area with known widespread deficiencies. But blanket supplementation isn't usually recommended without checking levels first. Lifestyle modifications like regular exercise, as tolerated and appropriate, stress management, getting enough sleep, these are often advised anyway, especially to help manage associated cardiovascular risk factors that can sometimes accompany even subclinical thyroid dysfunction. And here's a broader but very important piece of advice. It's vital for patients and doctors to maintain an open mind about symptoms. Common, nonspecific symptoms like fatigue, depression, anxiety, weight changes. They can have many causes beyond the thyroid. Could be cardiac, pulmonary, other autoimmune conditions, psychological issues, or simply lifestyle factors like poor sleep or high stress. Keeping an open mind ensures a comprehensive diagnostic approach so other potential issues aren't missed just because a thyroid condition is also present. Lastly, some specific points. Patients with Graves' disease who show any signs of eye involvement should definitely have a consult with an ophthalmologist specializing in thyroid eye disease. And for women, close monitoring and specific treatment choices, like using PTU in the first trimester of pregnancy, are essential during pregnancy and family planning because of thyroid hormone's critical role in fetal brain development. Awareness of potential issues like neonatal thyrotoxicosis is also important for families.
Wow. What an absolutely incredible journey into the world of the thyroid. It's just so clear that this tiny gland has such a monumental, far-reaching impact on our entire well-being, influencing everything from our energy levels, our weight, our heart health, even our mental clarity. It truly is a master conductor for our body's complex symphony.
Indeed it is. From its really foundational role in just basic metabolism and development to the incredibly intricate dance of autoimmune responses we see in Graves and Hashimoto's. And then the subtle yet significant influences of diet, environment, and our overall metabolic state. Understanding the thyroid is truly a deep dive into the body's magnificent complexity. The research we've discussed today really underscores how dynamic and interconnected all our physiological systems truly are, and how many seemingly unrelated symptoms can sometimes trace back to this one crucial gland.
Yeah, and it genuinely highlights the power of knowledge for patients, doesn't it? The importance of those daily habits, like how and when you take medication, and that crucial partnership with your healthcare team, the way you take your meds, the balance in your diet, maybe even how you manage stress. It really feels like it all plays a part in keeping this tiny powerhouse functioning as optimally as possible. So maybe a final thought for everyone listening. Next time you feel a bit off, perhaps ask yourself, beyond the obvious, what else might be stirring, maybe unseen, in your body's complex symphony? The thyroid definitely reminds us that balance is everything, and that even the smallest conductor can orchestrate a grand performance or sometimes a quiet pause throughout your entire life.